Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual, and today some more important clinical care tips and rules. Rule number 209. When the screening test is negative, consider stopping your workup. So this rule was inspired by a patient I had a few weeks ago in the ER, and for whatever reason, the patient was sent by the primary care for a concern of a kidney problem, and the primary care specifically indicated that the patient needs a UA, blood test, and a kidney ultrasound. So as I told you before, unfortunately, it's very challenging when the primary care sends a patient to the ER with certain expectation that certain tests will take place and doesn't leave it to the judgment of the pediatric emergency medicine physician, aka the specialist. Nonetheless, the patient is in the ER, so we might as well take care of it. And as the primary care suggested and was worried about, I obtained some labs that were all normal and a UA that was all normal. At that point, because the UA was normal, there's no proteinuria, there's no hematuria, because the BUN and creatinine are normal, I find it hard to believe the patient actually needs an ultrasound. Ultrasound of the kidneys, I think, is very unlikely to be of any use or any help if the BUN, the creatinine, and the urine, which I would consider the screening test for the normal kidney, are normal. I had that discussion with the parent who was still very worried, appropriately so, and again had some expectations about what will happen in the ER, and we did a kidney ultrasound, and guess what? It was normal. And that's when this rule came to my mind. We have screening tests such as BUN, creatinine, and urine analysis for a reason, and when those tests are negative, being the screening tests that they are, it is incredibly unlikely there's any pathology in the kidney, and I would argue that no further research or further workup is necessary. I think it's very hard to have any significant finding on the ultrasound when you don't have proteinuria, you don't have hematuria, your BUN and creatinine are normal, etc. So when your screening tests are negative, consider stopping the workup. Another good example for this rule is the PEM head injury rule. We all know the PEM head injury, we use it all the time, and when the PEM head injury indicates very low risk for clinically important traumatic brain injury, I don't think any of us sends the patients to head CT. I think we all consider PEM as a good screening test for clinically important traumatic brain injury, and when the screening test, aka PEM, is negative, I don't think many of us, hopefully none of us, really do CT for the patient. It's money, it's cancer, it's radiation, etc. And when the screening test is reassuring, there's really no indication for it. And trust me, I can go on and on. When the pediatric appendicitis score is low, personally, I don't send the patient to ultrasound and I don't call the surgeon. I just tell the parents what to watch for, what to come back for. But when the pediatric appendicitis score is negative, the chance of appendicitis is very low. And clinically, there's really no indication to pursue this further with imaging. So when your screening tests are negative, consider stopping the workup. Rule number 210. When you find a femur fracture, at least think about child abuse. And this, I gotta say, is something that I've been struggling with for a very long time, even though the work I do with child abuse, which is now quite extensive, this is always a tricky situation. And some people, I think, are very confused about it. I was confused about it for a very long time. What exactly is the relationship between femur fracture and child abuse? One thing I'd like to clarify right off the bat is the confusion between spiral fracture of the femur and spiral fracture of the tibia in a toddler. I think the word spiral fracture confuses a lot of people and makes a lot of people very concerned about child abuse. So let's clarify that right off the bat. Spiral fracture of the tibia in a toddler is known as a toddler's fracture and is rarely an indication for child abuse. It's actually quite a common finding. However, the femur, being the strong bone that it is very hard to break from non-significant injury, and when the femur is broken, especially if it's a spiral fracture, one should be very worried about child abuse. One study I came about that was very important in clarifying this confusion was a study by Keith Baldwin called Femur Fractures in the Pediatric Population, Abuse or Accidental Trauma, and I'll put the link in the show notes. And basically, the group in that research indicated that when there is a femur fracture, really you should be thinking about child abuse and put it together with some other risk factors that you can elicit by history and physical exam. The risk factors that the authors found were significant were history that was suspicious for abuse, that's pretty obvious, physical or radiographic evidence of prior injury, and age younger than 18 months. And the more you think about it, the more it makes sense. Patients that are younger than 18 months really rarely generate enough momentum in their daily life and movement to be able to sustain a femur fracture. And obviously, if there's history of abuse or any other findings, you really should put it together and suspect that the femur fracture is from abuse. In their study, patients who had no risk factors had 4% chance of having abusive injury, with patients with one risk factors had 29%, and patients with two risk factors had 87% chance of abuse. Patient with all three risk factors had 92% chance of having the femur fracture secondary to abuse. So when you see a patient with femur fracture, put it together, think about those risk factors, and be very suspicious of child abuse and work up the patient further. Rule number 211. Don't practice based on the exceptions. I would start by saying a small disclaimer that every rule has exceptions and exceptions always should be taken into account. But I think it's very important to not practice daily based on the exceptions. And this rule came to my mind after I saw a child that was sent to the pediatric emergency department with concern of appendicitis. To my surprise, when the patient came in, he complained of left lower quadrant tenderness. And I actually spoke to the physician who sent him, who was very worried about appendicitis, and we had this discussion. The patient did have some tenderness, however, had a very reassuring exam otherwise, and the patient clearly had pain in the left lower quadrant. When I spoke to the physician who sent him, he indicated that yes, you can absolutely have left lower quadrant tenderness to palpation with appendicitis. And while I agree with him 100%, it's a very, very rare exception. By all means, most children, by far, most children with appendicitis have right lower quadrant tenderness. We all know it. And while left lower quadrant is certainly possible, it's the exception. And when there's left lower quadrant tenderness, especially with reassuring vital signs and physical exam, etc., I would argue that an ER visit is not necessary. Yes, there are some patients who experience left lower quadrant tenderness with appendicitis, but it is a very big exception, and I don't recommend sending a child to the pediatric emergency department based on the exception and the very small chance that he or she may have a surgical abdomen. Now, with regards to this rule, I would argue for the same reason that I personally don't believe that every child that comes to the pediatric emergency department with chest pain needs to have an EKG. ST elevations or arrhythmias or really most cardiac findings causing chest pain are very, very rare. And it's very rare for children to have cardiac finding when they come to the pediatric emergency department with chest pain, especially when the physical exam is reassuring, especially when the vital signs are reassuring. I remember speaking to a cardiologist who told me it's almost impossible to have a cardiovascular abnormality when your vital signs are normal. It sounds very logical. So I don't necessarily get an EKG and or a chest x-ray on every child with chest pain. I would argue that if you're a normal, healthy child with no family history whatsoever, with vital signs that are very reassuring, and especially if the exam is consistent with tenderness to palpation, I'm not necessarily convinced that you need an EKG and chest x-ray. To me, that sounds like practicing medicine based on the exceptions. Yes, cardiac etiologies do exist in patients. However, those patients don't necessarily look well, don't have normal vital signs, are not tender to palpation because it's not a chest wall injury or chest wall problem. And I'm not sure every patient with chest pain needs an EKG. Are there any children out there that have cardiovascular abnormalities? By all means. But I wouldn't recommend getting an EKG and chest x-ray on every patient with chest pain because basically then you're practicing medicine based on the exceptions. And that is it for today, guys. Thank you very much for listening. Let's briefly review what we learned. Rule number 209. When the screening test is negative, consider stopping your workup. Yes, you can work up every patient for appendicitis. You can send every head injury to CT, but when your screening tools are negative, namely the pediatric appendicitis score and PCARN, consider stopping the workup, provide reassurance, good anticipatory guidance, and send the patient home. Rule number 210, when you see a femur fracture, at least entertain the possibility of a child abuse or non-accidental trauma. Put it together with some other risk factors if they exist and consider working up the child. Rule number 211, don't practice medicine based on the exceptions. Yes, exceptions exist, but they are the exceptions. But if you practice medicine based on the exceptions, you're going to end up working a lot of patients up, finding a lot of incidental finding, and keeping a lot of children in the pediatric emergency department for a very long time. My personal advice is to follow the guidelines, follow your screening tests, use those validated tools, and don't practice based on the rare exceptions. And that is it for today, guys. Thank you very much for listening to PEM Rules. Thank you again for all the support and all the downloads and all the comments. Again, everybody is invited to come on the podcast and discuss any pediatric emergency medicine topic of your choice. If it's an interesting patient that you saw in the PGR or in the ER and applied the rules, or even if you didn't, I would love to hear about it. Send me a text, send me an email through the website, etc. The following outro is a little blues riff that I've been working on in A minor. I've been working on my soloing techniques, getting better a little bit at a time. Hope you like it. Have a great day.